Hello, I'm Dr. Ann Milanese. I am a developmental behavioral pediatrician. My academic appointment is at the University of Connecticut School of Medicine, and my work life is based at Connecticut Children's Medical Center. At Connecticut Children's, I'm the medical director of Education and Rehabilitation Services, and so one of the major efforts that I make at the hospital is to provide clinical oversight of the rehabilitation service. One of my services at Connecticut Children's is the inpatient acute rehabilitation service, and this provides the basis for discussion today of acquired brain injuries in children. So an acquired brain injury is any injury to the brain that's sufficient to result in a change in either level of consciousness or an injury that brings about some anatomical defect or lesion to the brain. Typically, acquired brain injuries can be acquired either through trauma or through non-traumatic means, accidents, strokes, brain tumors, infections, any period of loss of oxygen to the brain. And so we'll be talking about both, but we have used traumatic brain injuries as a model for understanding brain injuries in children. So today we'll be reviewing some different types of brain injuries. We'll be thinking about risk factors and prevention of brain injuries, and we'll be overviewing how rehabilitation services work together to bring children to a level where they can leave the hospital and re-enter their communities. A good influence on the outcome of a brain injury has to do with management of the child at the scene of an accident. If it's a traumatic brain injury, the condition of a child at the scene of the accident and the medical and surgical care that's given in the first week after the injury occurs play a large role in determining the outcome and sequelae or after effects of the brain injury. It's really important to prevent consequences that have to do with lack of oxygen, hypoxic consequences, because those can complicate recovery in ways that are very difficult to get ahead of. Interestingly, when children have brain injuries, they present with physical problems, and then they present with what are more invisible psychological or cognitive problems. And the recovery that we see in the short term is often a physical recovery. It's kind of a fooler because the families and the staff are often very, very encouraged with how the kids recover their motor skills. So they walk and they talk and they feed themselves. And then there are the invisible parts of brain injury, the neuropsychological consequences, the academic outcome, the behavioral difficulties with regulation, interpersonal issues that really complicate the sort of medium-term recovery. And by medium-term, I mean maybe 1 to 2 years after the injury. And so that's the invisible handicap that comes from a brain injury. Brain injuries are graded by severity, and they range from the mildest brain injury, it's called, or concussion, to more severe traumatic brain injuries. And I think recently we've been paying a lot more attention to children who have concussions. In the old days, if a child was playing soccer and got hit on the head, had maybe a momentary confusion or loss of consciousness, they were given a drink of water and sent back into the game. And we now know that these concussions or mild TBI, mild traumatic brain injury, can really take a little bit longer to resolve. The good news is that the vast majority of them do resolve, but actually the risk of non-resolution or more permanent damage occurs if a child incurs a second concussion. So, for example, a child who might be sent back into a football game and then get hit in the head again, and those children are at risk for having more permanent and more significant consequences. And some of the consequences include physical things like blurred vision or headache, And some of them are a little bit more nebulous, but no less significant, like difficulty processing information and some cognitive problems. And so the mild concussions are something that we really need to pay a lot of attention to, and preventing them through the appropriate use of protective equipment is very important. Teaching coaches and other athletic trainers to recognize them is very, very important. And then encouraging parents to allow the children a period of rest after concussions occur so that brain healing can occur. So children should have a period of cognitive and physical rest, and then they should have sort of a graded return to play. So that's what I wanted to say about the mild injuries. There are other kinds of injuries that are non-traumatic that happen to children, ranging from mild to severe. These include strokes, post-infectious complications. Kids who have encephalitis can sometimes have consequences, and kids who have brain tumors certainly can have periods of or incidences of neurological outcomes that need to be addressed. There are certain children who are more prone to incur brain injuries, particularly the traumatic brain injuries. These are the kids with the pre-existing behavior disorders, conduct disorder, ADHD, children from socially disadvantaged backgrounds. These are the kids that are at highest risk for having traumatic brain injuries. Children who have brain injuries, either traumatic or non-traumatic, are often not the same after the injury. As a result, they're at risk for depression and other psychological difficulties, and they need support, as do their families. There are certain risk factors that predict a better outcome. Certainly if a child is in a coma, the shorter the better. Coma of less than 6 weeks is a good indicator. If a child has had a concussion, less amnesia associated with the concussion is an important positive predictor. Less multiple organ damage from major trauma, and the absence of pre-existing developmental conditions would predict a better outcome. The challenge after a child is cared for in the hospital is to collaborate many sources of resource for the child. Often this includes family members, educational staff, community therapists, and agencies all working together to support a child's medium term, that is 1 to 2 year progress, as they make their way back to their lives, recognizing that they may never be the same, but that the passage of time and good quality experiences go a long way to help them reinstate their momentum.
Thank you very much.
Okay.